selective cannulation of the desired duct is the first and the most important step to perform any interventional endoscopic procedure in the biliary or the pancreatic tree. Whenever we want to do selective cannulation of the bile duct, we usually start off by keeping the patient in the left lateral position. The main reason is, in the prone position, sometimes it may be difficult to pass through the stomach and go into the duodenum because of compression of the stomach. So in this comfortable position of the left lateral, the scope is initially introduced through the esophagus, through the stomach, and then through the duodenum, so as to position the ampulla of Vater in the correct axis for cannulating the bile duct. We use this duodenoscope, which is a therapeutic channel duodenoscope. And as you can see here, before we begin, we lock the small wheel of the duodenoscope in the center, so that by moving the big wheel, the scope moves in only one plane. This is an essential step, so that while going across the tongue, the patient will not push your scope to one side by means of the tongue. After this step, then the scope is held in this position, and then the big wheel is moved. By moving the big wheel towards you, the scope tip comes towards the anterior part of the patient. By moving the big wheel away, the scope goes towards the back of the patient. By keeping the big wheel pressed little away, the scope is gently introduced behind the tongue. If you see the endoscopic picture, you get an exactly inverted position, and you see the tongue in the upper part of the picture. Once you reach this stage, the big wheel is moved upwards so that the scope goes behind the tongue, and we reach the area of the cricopharynx. You can see here, this is the vocal cord and the cricoid cartilages. At this level, the scope is again, the big wheel is made little away, and then with a left twisting movement, the scope is gently pushed so that it passes across the cricopharynx inside the esophagus. Once you have entered the upper part of the esophagus, the locked small wheel is released, and then the scope is held in this position, and the big wheel is again pressed slightly away, so that the side viewing scope is converted into an end viewing scope, and you can actually see part of the lumen of the esophagus as you are going through. So with slight rotatory movements of the shaft, the scope is gently pushed until you reach the OG junction or the cardia. Once you reach the cardia, by twisting the scope to the left, you can see the fundus, and you can see some gastric fluid. It is always a good idea to go inside the fundus and suck out the gastric fluid, and then after reaching this level, with a gentle right turn of the body and the shaft of the scope, you can see that the scope orientation goes towards the longitudinal folds towards the antrum. And then by gentle up-down movement of the big wheel, the scope is passed along the greater curvature of the stomach until you come to the mid-body. At this level, you start seeing the incisura angularis and the pylorus ahead. So keep on passing the scope along the greater curvature, trying to keep the pylorus somewhere in the center. You can see that the pylorus is somewhere in the center. And as we go ahead, and once the lower lip of the pylorus disappears, we push the scope so that the scope enters the duodenal bulb. After we enter the duodenal bulb, we should not be in a hurry to turn the small wheel right and fix it. At this level, push the scope slightly more inside and then turn the body to the right, by which we start seeing the junction of the first and second part of the duodenum. Once we see the junction of the first and second part, at this time the small wheel is turned to the right and then it is fixed. Usually at this level, you can see the minor papilla which comes into the view. You can see on the right hand corner of the endoscopic picture, there is a small bulge which is the minor papilla, and below you see the bulge of the major papilla. So this is the exact positioning where the minor papilla is located. So then by turning the small wheel completely right and fixing it, the scope is gently pulled backwards, and as we are pulling it backwards, the big wheel of the scope is turned towards us. With this, the scope is passed beyond the ampulla of Vater. After this is done, the small wheel which is locked is unlocked. It is derotated. The big wheel is pressed again away, and then the scope is gently pulled back so as to bring the ampulla of Vater in view. You can see that the ampulla of Vater is now well seen, and it is somewhere at 12 o'clock in position. The ideal position of the ampulla of Vater for cannulating the bile duct is to bring the ampulla at 11 o'clock, and this can be done by simple shaft movements. You can see this just by moving the shaft from the right to the left, and then by holding it, the ampulla remains in a stable position somewhere at 11 o'clock in the endoscopic field.